When you can change the system and when you can educate early and improve access, you can actually have a much bigger impact overall. IVF is an incredible technology that can help individuals and families have children, but it is not a fix for everything. I have a lot of patients say, oh, I wish I had known about this sooner. I'm kicking myself. I wish I knew we were going to delay childbearing for a couple of years. I wish I had frozen my embryos. The biggest misconception about IVF success rates is that one cycle equals one baby. Egg freezing is something that it's not a perfect technology. It's definitely not for everybody. And I think for a long time, it was probably overpromised. Like what it could do is probably overpromised. In a fertility world, you can't control a lot. You can't control age. You can't control number of eggs. So you want to control what you can. And what you can control is decreasing exposures, right? Decreasing alcohol use, no smoking of anything as best as possible, getting enough sleep. All of those things are within a person's control, and within fertility, things can feel very much out of control.
Welcome, Dr. Randi Goldman, to the Dismantling You podcast. I'm so excited to have you here today. You have an exceptional educational background. You trained in Boston at Harvard, and you now lead fellowship training at Northwell Fertility. How has your philosophy changed around fertility care?
Thank you so much for having me here, Lisa. It truly is an honor.
My pleasure.
Yeah, so I have been sort of all over the Northeast in my training and am very lucky to be in the role of the program director for our fellowship. I think, when I was in training personally, a lot of what I did was driven by the person who was in front of me. And I was very focused on that individual patient, individual care outcomes. And I think what I've learned over time is that when you can change the system and when you can educate early and improve access, you can actually have a much bigger impact overall. And that is something I think that has changed over time for me.
Now, what are the biggest changes you've seen in fertility trends over the last decade?
Oh, that's a great question. So, in the last 10 years, it seems like our field moves at the speed of light. There are things that years ago, 20 years ago, might have seemed like science fiction in our field. One of the biggest ones, I think, is education and social media. Mm-hmm. To believe it or not, our patients are coming in knowing a lot more and having a lot more of the background than they did in prior years. And this is a good thing. I think people are sharing their stories, sharing their journeys. And so we're seeing patients with a lot more informed decision-making upfront. Before they even walk in the door, they often have a big idea of what they would like. I think that is something that has changed hugely. And of course, our science is moving so quickly that the patients that we're able to take care of is different. Ovarian tissue freezing, which is one of the ways that very young girls can preserve their fertility, is something that was more or less an idea, more than 10 years ago, and really has grown to expand access to that very, very critical treatment option for patients, and it didn't exist before.
Yeah, so the internet has created so much access, but there's still so much noise out there. And that being said, what are patients most misinformed about when they walk into your office?
I think that they overestimate what IVF can do. IVF is an incredible technology that can help individuals and families have children, but it is not a fix for everything. It's important, but I think that one of the big things that they overestimate is the success with IVF. I hear a lot that patients will say, if X, Y, or Z doesn't work, I'll just do IVF, assuming that it's going to be the cure-all for their infertility, when the reality is there's a lot more to it than that. And IVF is just one small piece of a larger puzzle.
Do you believe trimester zero exists?
I think conceptually trimester zero definitely exists. So trimester zero being, the 3-ish months before a person is going to try to get pregnant, I think is a really critical time where people can optimize their chronic health conditions, take a look at the medications that they're on to see if they are on a medication that is safe in pregnancy. They can kind of look holistically about what they're putting into their bodies. Am I drinking too much alcohol? Am I smoking? That's kind of the biggest benefit that a person can do, is if they're smoking, to stop. So I think in that way, it definitely can exist. And it's also a nice time for women to start tracking their cycles, to know if they are getting regular periods, which would suggest that they are ovulating. So I think it's a really good time to prepare for pregnancy in that way.
What do women misunderstand about ovarian reserve versus egg quality?
Great question. So ovarian reserve in most circumstances really refers to egg number. How many eggs does a person have? And for the most part, we believe that people who are born with ovaries, women are born with a set number of eggs. And that notion is being challenged a little bit. But when we think about egg reserve, we really think about number. For egg quality, that typically refers to the proportion of eggs that is expected to be healthy, genetically healthy. So, for example, a person who is 43 can have an excellent ovarian reserve, a great number of eggs in their ovaries, but it doesn't mean that their quality is going to be high. It just means that the number is going to be high. So I think oftentimes the two get kind of conflated with one another, but in reality, they represent different things that are both important for fertility.
And that distinction is so important. Now, at what age should women realistically start thinking about fertility testing?
So that's a great question too. So, I am a fan of early education, and I think that knowledge is power and is really important to allow people to make decisions that are right for them. That being said, do I think that, an otherwise healthy 19 or 22-year-old needs to necessarily worry a lot about their fertility or request a workup? Not necessarily. I do think it's important for people who might have a history of something that can threaten their fertility. For example, if they previously got exposure to chemotherapy, cancer history, they maybe have endometriosis, I think then it might be important to do kind of an earlier workup. But otherwise, I think that in the low 30s might be a good time to think about it, especially for people that are pretty sure they want to keep on the table having a biological child, but it's not something that's necessarily going to be immediately on the horizon.
How reliable is AMH and follicle counts in predicting fertility?
Ooh, not very well. So AMH and AFC, antral follicle count, FSH, are quite good at predicting how well somebody will respond to our medications from a fertility doctor's standpoint. So how well a person will respond to IVF medications, what number of eggs might you get. And it really is not good for predicting whether or not somebody will be able to conceive on their own. And I kind of think about it in this way, that if a person has an AMH of, 0.4, 0.4 versus 4, they're generally still only ovulating that single egg in the month, right? They've got lots of other eggs there, or maybe not so many, but that one egg that's ovulated is going to determine partially whether or not somebody will be able to conceive. So they are not very good at predicting unassisted pregnancy.
What does a full fertility workup look like today?
Fertility workup, there's a lot of different parts to it. When I think about the fertility workup, I like to think about what orchestration of events has to happen correctly in order for a sperm cell to fertilize an egg. So you want to look at egg number. There isn't really a test for egg quality. That's more based on age. You want to look at the uterus, make sure the uterus is healthy, look at the fallopian tubes, make sure that they're open and don't look damaged. You want to look at other hormones that can influence fertility, like thyroid stimulating hormone is a big one. The thyroid is really important for metabolic health and fertility. And then, of course, we can't forget our male counterparts. Infertility and fertility is highly driven by the sperm in the male. And so I think it's important that at this point in time, the fertility workup is a couple's thing when you are a couple rather than an individual. And so it's important to kind of look at everything together. So egg number, hormones, uterus, tubes, and sperm are the big ones.
What red flags in labs or imaging immediately concern you?
Well, if I see an otherwise healthy young person with a very, very low AMH or a very low egg count, that does tend to concern me. I start to, kind of worry, might they have some other extrinsic factor influencing the number of eggs, like endometriosis, for example, tubal damage. So bilateral, both sides of the fallopian tubes being blocked, that tends to be concerning. And also severe male factors. Very, very low sperm count, very, very low motility, where I would worry about the sperm's capacity to fertilize the egg.
For listeners who are unfamiliar, explain to us what is endometriosis, what are the symptoms, and could it possibly be related to unexplained infertility?
Yeah. So, we're coming off of Endometriosis Awareness Month too. And so this is, I think, a really important question. Endometriosis is a very common disorder that impacts women, where the inside cells that typically line the uterine cavity, where, an embryo would stick, find themselves in places that they don't belong. And kind of the way that this happens, there's a few different theories about it, but essentially you have endometrial-like cells that are outside of the endometrium. So it can be impacting the ovaries, the kind of organs that are in the pelvis. It can stick to the bladder, the bowel. It can impact the fallopian tubes. It can cause scar tissue. And so endometriosis is a very kind of inflammatory disease that can influence fertility in a negative way. So it's estimated that about 50% of women with endometriosis will have infertility. And one of the challenges with endometriosis is that it's not something you can see. And so unfortunately, it tends to go undiagnosed or misdiagnosed for many, many years. And oftentimes, patients don't know that they have it until they come into my office. And at that point, there might be signs or symptoms on imaging or just from medical history that would suggest it. And what might have previously been thought of as unexplained infertility can then be described by, well, you've got endometriosis. You've got this thing where we know that about half of women are going to be impacted, with their fertility is going to be impacted. So I think it's a really important thing to educate about, and very happy to report that just in the last week or two, there's been kind of new diagnostic criteria that allow for a more clinical diagnosis of endometriosis without the need for surgery, which was something that in the past was required.
So we often hear about who should consider egg freezing. What about who would you recommend that don't need it?
That's a good question. So for egg freezing, I think egg freezing should be on the table for anybody who is maybe getting on in their reproductive years, where having a baby is not something that's going to be done immediately. They're not going to try right now. They might be focused on career, focused on other things in their life, perhaps be, not partnered right now, not wanting to use a sperm donor at the moment. So that's, I think, a good population of patients who are going to think about egg freezing. But egg freezing is something that it's not a perfect technology. It's definitely not for everybody. And I think for a long time, it was probably overpromised. Like what it could do is probably overpromised. And I think it's really important that when we're offering this, we are able to tell patients the risks, benefits, and the limitations to the technology. So, for patients who are in their, mid 40s, for example, egg freezing would probably not at the end of the day result in a baby. So I think that for patients who assume that egg freezing is going to be a guarantee, they probably shouldn't do it or should be more educated prior to making that choice. There's definitely a population of patients where I don't think it's necessary. And for very, very, very young patients, under 20, for example, while certainly you can, the earlier you are when you freeze eggs, the less likely you are to need them. So I think there's a kind of financial aspect to that as well. Of course, the emotional, the physical toll that it takes. So I am a fan of a lot of education and a huge proponent of patient autonomy. So I tend to let patients drive that decision at the end of the day once I feel like I've counseled them appropriately, but probably not for patients that are already very advanced in their reproductive years.
What is the biggest misconception about IVF success rates?
The biggest misconception about IVF success rates is that one cycle equals one baby. I think that it's important that we tell people that IVF success rates are cumulative, which means that multiple cycles is often needed to have a baby and that there's not a guarantee, and that the success with IVF is highly age dependent. And I think that those two concepts are often, I would say, a little bit misunderstood with it.
Yeah, it's interesting because patients often misinterpret this as guarantees this success, but it's obviously individually and based on their biology. How do you counsel patients choosing between embryo freezing versus egg freezing?
A lot of it depends on partner status, I will say. So egg freezing uses a person's own genetic material. So from a legal standpoint, that tissue belongs to them. They are the sole owner of that tissue, if you will. And so for patients who are hoping to use that egg with a future partner, egg freezing is typically done. Now, I see a lot of patients who already know that they are going to be using a sperm donor in the future. And in that situation, we also, talk about embryo freezing. Patients who opt for embryo freezing, I would say more often have a partner and are pretty sure that that's the person that they are going to have a family with. Now, you could be very sure today, and you don't exactly know what tomorrow is going to bring. And it's a conversation that I have regularly with the people that I see. But embryos give you a little bit more information. So embryos tend to be kind of better at predicting the likelihood of success. In that, I mean, an embryo came from an egg that had to prove itself in a lot of ways before it became an embryo. So, for example, a person who is under 35 years old, if they froze 20 eggs, their likelihood of having at least one baby is going to be about 90%. That's sort of the equivalent of 3 genetically healthy embryos, which will give you a likelihood of having a baby of about 94%. So when people hear those numbers, they think, oh my God, it's going to be 20 eggs is the same as 3 embryos. Well, yeah, you don't know if that egg is going to be competent to fertilization. You don't know if it's going to be able to be fertilized by a sperm. Only about 80% of mature eggs are. You don't know if the resulting embryo is going to be healthy. Is it going to be able to grow in the lab? There's a lot more questions, I think, from a single egg than a single embryo. But because our technology is so good these days, and egg freezing and thawing, and while not exactly the same in terms of success rates as an embryo, is really, really good, people tend to make the decision more on social factors, I would say, than behind the scenes at the lab.
What role does elective single embryo transfer play today?
Oh my gosh, it's so important. So it's one of the parameters that we are judged by, to be honest. How many, what's the proportion of transfers that we're doing that are elective single embryo transfers? And there was a report that came out a couple of days ago that in the last year, over 100,000 babies were born from IVF in the United States. And among those, 97% were singletons, one baby. And that's really different than IVF before, right? When we would transfer more embryos than we do now. I think part of that is that we're doing more genetic testing of embryos so that you're transferring an embryo that at least on paper looks healthy. And I think about 4 out of 5 transfers now across the board are elective single embryo transfers, which is a trend that I hope continues.
How much do lifestyle factors contribute to fertility success?
They're important. They're really important. Healthy lifestyle is not going to overcome age-related fertility decline, but it can help to optimize the likelihood within that biological window. And I think that in general for life, it's really important to know that what you are exposing your body to is important, not only for pregnancy or getting pregnant, but also for the health of the pregnancy in the future. So it is something that I do bring up. I think in a fertility world, you can't control a lot. You can't control age, you can't control number of eggs. So you want to control what you can. And what you can control is decreasing exposures, right? Decreasing alcohol use, no smoking of anything, as best as possible, getting enough sleep. All of those things are within a person's control. And within fertility, things can feel very much out of control. This is something that is very tangible that a person can absolutely change. And I think it's actually a very powerful thing. A lot of people don't necessarily stop smoking, et cetera, for themselves. They might do so for a future pregnancy.
What role does stress and sleep play hormonally?
Great question. So, and this is always a hard one, I think, because I don't know a single person walking into my clinic who's not stressed. And I would say you don't want to have this cycle where you're stressed about being stressed, right? Stress is okay. Stressed people get pregnant. I don't want you to be stressed. But people who are stressed, who have anxiety, get pregnant all the time. That being said, can it influence ovulation every once in a while? Yes. Sleep is also really important. It has to do with the hypothalamic pituitary ovarian axis, which is sort of how the brain communicates with the ovaries. And sleep is really important. The same hormones that are influenced by sleep are the hormones that are causing our bodies to ovulate. But typically, it's not going to be the only cause of fertility. You can't be so stressed forever to cause infertility permanently, but it is definitely a contributing factor.
What are the most evidence-based ways to improve fertility naturally?
So a lot of this has to do with exposures, decreasing smoking, decreasing alcohol use. Make sure that you are on a prenatal vitamin. That's good for the health of a pregnancy. And then I talk to my patients also just about tracking of cycles. And it's something that might seem like, oh yeah, everybody's doing this and very obvious. But I see a lot of times people are not necessarily understanding their cycles as they should be. It's not something that's routinely taught in that way in school or in college. Even other medical professionals don't always understand their menstrual cycle. But that I think is a really important thing that can help to optimize things, just in knowing when to try. That also it doesn't only fall on, the female partner of a relationship. The same is true for their male counterparts. Decreasing exposures, improving sperm counts as they can in a natural way.
What is the hardest conversation you've had regularly with your patients?
There's one that I really don't like to have, which is when I see a couple come in who might be a little bit more advanced in their reproductive years, who say, oh, I spoke with my doctor 5 years ago and they told me not to worry about it. They told me I didn't need to fertility workup or what have you. It's hard to have people come in who have been previously reassured about something that maybe was a problem or could have been a problem. I have a lot of patients say, oh, I wish I had known about this sooner. Right? I'm kicking myself. I wish, I knew we were going to delay childbearing for a couple of years. I wish I had frozen my embryos. I think that's a really hard conversation to have. And I think really comes down to the importance of educating not only our patients, but our colleagues as well. That's a hard conversation. And then I would say when we have the conversation, if it comes up about the kind of moving past and thinking about oocyte donation or egg donation, that can be a very difficult conversation too, because it can feel like a loss in some ways to patients. And, egg donation is an absolutely beautiful and wonderful technology that helps bring families together. And that being said, it is a big step for some people to take. But having that conversation and reassuring them that whether you have a baby from your own oocyte or a donor, it's going to feel the same. People don't always believe that, but I tell them I have patients who have done both and they come back and they reassure me it feels exactly the same. But those are always hard conversations to have.
How do you guide patients emotionally through infertility treatments?
I tend to be very open and transparent. I tell them that it's not always going to be easy from the beginning and that they know that I am always there to ask questions of and rely on. I tell them to look everything up on Google. I know people say, don't Google it. I say, Google everything and then come back to me with your questions, because I never want you to feel that, you have this burning question and you don't want to offend me by ask me every single question. My patients have a very easy way of getting a hold of me, which I think is really important as we navigate this journey together with them. And I always tend to have a plan. So even if I'm maybe not calling with the best news, I make sure that I have, at least in my mind, what the medical recommendations could be, so that they know that there is going to be a next step and that I'm always there for them. And that if it's going to come to the point of having that hard conversation, I will do it. And I think that that's not easy. I tend to be a person who takes a lot home with me. And, I really care about my patients and their success. So I think although it's very difficult, it's an honor to have those conversations, but I try to be as transparent and open and honest about what the next steps would be, because that's what I would want.
What do partners often misunderstand about infertility?
Depends on the partner. Yeah. I have some partners who are so absolutely, in tune with everything that they're the ones that remember when their partner's last period was and the partner has no idea. I have patients like that. But I'd say, sometimes it can be very difficult for a partner to understand the mental and emotional and physical toll that the hormones that we give can sometimes take on a patient. I think going through fertility treatment, everybody deserves a whole extra lot of grace as they go through it. So, I think that that's one of the things that can be hard to understand, just because they are not living through it themselves, in that the hormones can cause not only emotional changes, but physical changes. And, there's a lot of guilt that can be felt within that. And so I think that that's something that they should definitely take home.
What was the catalyst for joining Rune in the AI medical space?
So I joined Rune pretty early, I will say. I was one of their first fertility docs on. And I think that there is a lot of information out there. Anybody can post on a blog or an Instagram reel or whatever that might be. There's a lot of information. And I think it's important people share their stories. But at the same time, there is a whole lot of misinformation out there. And patients that are navigating a fertility journey are in this uniquely vulnerable situation where they would do anything sometimes to have a baby. You say stand on your head for 3 hours, done.
Yeah.
Right? If they think that's going to help, they'll do it. Is that going to help? No. But, when you're grasping at anything to try to get that goal, right, you are sometimes more susceptible to that misinformation. And so I thought it was important for me to use my voice, my education, my experiences to help educate colleagues and patients on fertility. And I'm really grateful that I did it. Yeah, it's nice to be able to share information in that way and to know that you are adding to the accurate evidence-based information out there.
No doubt, interpretation still requires medical wisdom. How do you see fertility care evolving over the next decade?
I'm so excited to see where it goes. I sometimes look back and I'm just totally flabbergasted at how far we've come. I think genetics is going to play a big role. And as that continues to evolve, our genetic capabilities are going to increase. I'm hoping that access continues to expand as well, because we still have a lot of barriers in access to fertility care, not only here in the US, but globally. So I'm hoping that is something that improves. And fertility preservation is something that I feel very strongly about. As we are able to treat things in ways that we were previously unable to treat. For example, we can cure beta thalassemia and sickle cell now with a stem cell transplant. The treatments for that can truly change and improve somebody's lives, but can cause permanent infertility because it takes chemotherapy. For a while, we thought medical egg freezing, medical fertility preservation only meant cancer. It means a lot more. And so I'm hoping that our access to preserving fertility continues to increase over the next 10 years. And who knows where AI is going to go. I have a feeling that there's going to be, in the next 5 years, what we do on a day-to-day basis, seeing patients and in the lab is going to be mind-boggling.
No doubt. I'm excited for sure. Ready for some rapid fire?
Yes.
Let's do it. Give me one daily habit that supports hormonal health.
8 hours of sleep.
Most overrated fertility hack.
Just relax. It'll happen. No, that doesn't work. That doesn't work.
Most underrated habit.
Cycle tracking.
Most common myth about IVF.
That it always will work.
And the last one is one thing every woman should understand by age 30.
Fertility declines earlier than you might think. There is not this sudden decline at the age of 35 where you fall off a cliff. It starts earlier than that. So it starts in the 30s.
Yeah. No doubt. Now, as you know, my podcast is based on dismantling thoughts and beliefs. What is a pattern or belief you once held on to that you had to unlearn?
When I started out as an attending and in training, it was always about the immediate next step for me. I'm looking at this one patient. How am I going to fix this patient's problem and help that patient reach their goal? I had to rewind that and say, by the time a patient was in front of me, their trajectory has already been set. So I had to really take the time to learn about how the education and the systems themselves influence the patient's lives before I even met them, before they even walked in the door. And I think that that's something that takes longer. It's a little bit less tangible than the patient in front of you. But I'm hoping and still learning, but able to influence things on a larger scale and influence more people, even though they're not necessarily an individual, win for me or that patient. The group wins are even more important and more powerful.
And medicine often comes with questioning, with things that we thought were certain. What are you currently doing for self-care?
It's definitely something that I've had to cognizantly work on. And I'm taking time for myself, and I'm being selective about the things that I say yes to, and also the things that I say no to. So I think, in the past, I always was somebody who never wanted to disappoint anybody and say yes to everything. And I've learned that if you do that, then you do a lot of things, but not as well as you could. But it's also not protective of your own time. So now I'm saying yes to the things that I want to do that excite me and that I think are going to make the biggest difference.
I find it meaningful to always find out what physicians are doing to care for themselves before others. Tell us, where can listeners connect with you and your preferred social media?
Yeah, so I'm an attending at Northwell Fertility. Can look that up and find me there. I am on Instagram. My handle is Randi H. Goldman _fertility doc. And then professionally, I'm also on LinkedIn.
Perfect. Thank you so much, Dr. Goldman. This has been such an informative conversation, cutting through the noise and giving people clarity. I appreciate your expertise. And thank you.
Thank you so much for having me. It's an honor.